webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of the many resources made available by the Prescribers Clinical Support Opioid System Opioid Therapies, a program that's funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. Today's webinar is in collaboration with our colleagues in Canada, the Registered Nurses Association of Ontario, and the Opioid Awareness, Treatment, and Education through the Center for Addiction and Mental Health. I want to go through a few quick housekeeping notes before we get to today's presentation. In the upper right side of your computer, you'll see a control panel. In the lower portion of that panel, participants can type in a question or comment, submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we're unable to get to all your questions in the allotted time, the presenter has agreed to respond to them in writing. The webinar, presentation slides, and questions and answers will be posted on the PCSSO website in the near future, as well as the INSA website at www.intnsa.org. Now let me turn to Sabrina Morelli, who's the Program Manager for the Mental Health and Addictions Initiative with the Registered Nurses Association of Ontario's International Affairs and Best Practice Guidelines Center. Ms. Morelli will introduce today's webinar presenter. Sabrina?
Everyone. On behalf of the Registered Nurses Association of Ontario, RNAO, and the Center for Addiction and Mental Health, the Opiate Awareness Treatment Education Initiative, I want to welcome you to today's webinar. The RNAO is a professional association for nurses in Ontario, and since 1925 has advocated for healthy public policy, promoted the excellence in nursing practice, advanced nurses' contribution into shaping healthcare systems, and influence decision-making that affects nurses and the public that they serve. A signature program of the RNAO is the International Affairs and Best Practice Guidelines Center, whose work focuses on the development, dissemination, implementation, and evaluation of clinical and healthy work environment best practice guidelines. One of the initiatives at the RNAO is the Mental Health and Addiction Initiative, funded through the Ontario Ministry of Health and Long-Term Care. The goal of the Mental Health and Addiction Initiative is to build capacity amongst nurses and other healthcare professionals to implement and sustain addiction and mental health best practices in daily nursing practice. To learn more about the RNAO, please visit rnao.ca. Our second partner in this webinar series is the Opiate Initiative at the Center for Addiction and Mental Health. The Opiate Initiative stands for Opioid Awareness, Treatment, and Education, and is funded through the Ontario Ministry of Health and Long-Term Care. The Opiate Initiative is involved with face-to-face education and training, with online training, webinars, dissemination of resources. The initiative works with people with lived experience to help share their voice, along with primary care professionals, allied service providers, family, and youth. It is our pleasure to be here with you today. Now let me introduce the speaker for today's webinar. It is my pleasure to introduce May Katz, who will be giving today's presentation. May is a member of the Temagami First Nations and nurse practitioner in Thunder Bay. Her nursing experience for over 30 years is diverse, and she has spent many years working with the 49 First Nations as far north of Canada in the territory Northern Ontario known as Anishinaabe. Her nursing background includes primary care, maternal, child care, community mental health and addictions, diabetes, and psychiatric care. May has completed a diploma in nursing at Confederation College, an honors Bachelor of Science in Nursing at Lakehead University, a Master's of Education with a degree in a curriculum specialty, and a primary care nurse practitioner at Lakehead University, all in Thunder Bay, Ontario, Canada. She is presently the treatment team coordinator that provides SUBOXONE treatment for opiate addiction at the Dennis Franklin CROMARTY High School, and the Mobile Treatment Team Program delivered in the Northern Remote First Nations communities. The treatment team comprises of a physician, a nurse practitioner, addictions counselors, and case managers, RNs. She is research affiliated with the Lakehead University site for the Center for Rural and Northern Health Research. As a member of the Center for Rural and Northern Health Research team over the past 23 years, she has taken the lead in developing appropriate knowledge transfer strategies for several projects done in partnership with the First Nations community. As well as her clinical background and research experience, she has worked for a number of years as a senior administrator responsible for Aboriginal health programs, both as the regional director in Ontario for Health Canada's First Nations and Inuit Health, and before that as the director of the Nishnawbe-Aski First Nations community. Thank you, May, for joining us today. Now let me turn it to you, May, to start the presentation.
Good morning. The title of my presentation is Opiate Treatment in Aboriginal High School Students in Ontario. We were faced with a challenge in 2011. We had 40% of our students in an Aboriginal high school in Thunder Bay that were known to be addicted to opiates due to the non-medical use of prescription opioids. These adolescents live in geographically remote, fly-in communities where opiate addiction is of a magnitude not seen elsewhere in Canada. Our addiction rates among those 15 years and older are as high as 80% in some communities. The Nishnawbe-Aski Nation is an Ojibwe Cree word that means the people and the land. It comprises 49 First Nations, ranging from 150 members to 2,000 members. The population of the area is 50,000. Predominant access to these communities is air access only, and this creates a high cost of all commodities, including black market drugs. The area is under Treaties 9 and 5, and in the last 2 years, I have made over 50 trips to these northern remote communities to assist First Nations with their opiate addiction problems and to bring treatment to the communities instead of sending people out to urban centers. So far, we've treated over 400 clients. This presentation looks at an innovative school-based opiate treatment and maintenance program designed for and by Aboriginal people using SUBOXONE, also known as buprenorphine naloxone formulation. Our approach to treatment is using low-dose short-term SUBOXONE combined with cultural, educational, and spiritual supports. This presentation will highlight the elements that contribute to its success while acknowledging the challenges faced. The information is based on an evaluation that reviewed students' medical charts and interviews with students, school administrators, and health professionals involved with the program. The Dennis Franklin CROMARTY High School has been operating in Thunder Bay since 2001. We offer grades 9 to 12 to 150 students from 24 remote Aboriginal communities. This region has seen over 451 youth suicides over the past 20 years. Many of our students have lost siblings and other family members to suicide. The abuse of OxyContin and other opiate drugs is a major health issue, with 63 of 150 high school students identified as addicted to opiate drugs in 2010. 75% of these students were injecting OxyContin. The affected students had high rates of absenteeism due to their addiction. Many were spending all day searching for drugs and experiencing symptoms of withdrawal, including restlessness, irritability, lack of concentration, being anxious, and GI upset. So why are we using SUBOXONE? To start the program, we did a literature review. The literature we reviewed, the clinical trials, came from the United States, Australia, and France. It identified SUBOXONE as the first-line treatment for adolescents. At the time, in 2010, there were no clinical guidelines in Ontario, so we used the U.S. guidelines for treatment. We use SUBOXONE as the reserves in the north have no access to methadone treatment, as there are no pharmacies, so other options needed to be identified. We found SUBOXONE to have a good safety profile, high efficacy, and low mortality risks. This medication can be administered in a primary care setting, which is less stigmatizing than conventional methadone clinics. This medication is also suitable for short-term detoxification and maintenance of adolescents and young adults. We conducted a pilot project that targeted 50 students to receive SUBOXONE treatment, and this gave the flexibility to the treatment team to adjust their protocols. Initially, we started out with a 14-day detoxification program that was offered to our first 10 students. It included 8 days of detox and 6 days of tapering off SUBOXONE. Many of these students relapsed, so we extended to 22 days, and our feedback from the students, that was also too short, and they relapsed due to the craving for opiate drugs. Our current protocol is a 30-day taper program with maintenance. We use the top dose of SUBOXONE is 16 milligrams. We do that because 93% of opiate receptors are covered at that dose. There's less risk with alcohol use. There's a safety consideration, and it gives us a shorter wean period. This includes detoxification for 9 days at 16 milligrams. We estimate it takes 7 to 10 days for the OxyContin to clear the system. After that, we decrease 2 milligrams every 4 days and end at 6 milligrams at day 30. After day 30, we do a short-term, low-dose maintenance protocol. Usually starts at 6 milligrams, as the students say they were still craving at 4 milligrams. That was our initial maintenance dose. We lower this dose 1 milligram every 2 months, so the duration of treatment is 12 to 15 months. During school breaks, SUBOXONE is administered at home in their home communities in the north by a responsible adult. We do an approach with a multidisciplinary treatment team. Our team is comprised of a physician. Her name is Dr. Claudette Chase. We started with 4 nurse practitioners initially to work with our first clients, and I'm the only nurse practitioner who's doing inductions now. We have a case manager who's a registered nurse and also the school nurse, and we have an addictions counselor. We targeted 5 intakes of 10 students each to reach our 50-student goal. Our team is responsible for the 4-day inductions, ordering lab tests, and doing symptom management from withdrawal, monitoring treatment, and changing treatment plans. Our school nurse, case manager, and addiction counselor is on-site daily for daily care and for the delivery of our aftercare activities. Initially, a pharmacist did direct observed therapy of SUBOXONE when we were using an off-site clinic pharmacy. Our treatment team have SUBOXONE education certification. As the coordinator, I did on-site observation at the Center for Addiction and Mental Health in Toronto. As a treatment protocol, we are now following the College of Physicians and Surgeons of Ontario clinical guidelines. It requires a history, a physical examination, lab tests, policies and procedures, which are given to each student prior to SUBOXONE administration. Each student must also sign a consent and a consent to be placed into Health Canada's narcotic monitoring program, as they cover the cost of SUBOXONE for the students. Our boarding homes and teachers are given information about the treatment, the symptoms to be expected in the first 4 days, and what to do in an emergency. We have only had one true allergy to the buprenorphine, and we confirmed that by communicating with the U.S. pharmacist who works for the Reckitt Benckiser company who makes the medication, and we can't use SUBOXONE with this client. During the initial cycles, daily transportation provided to and from the off-site clinic pharmacy was found to be too disruptive to classes, as they missed the first morning class. We do have a consultant who works with our program who does give us treatment principles only for any unusual responses to the clients. We work with Dr. Andrei Samakolov at CAMH in Toronto, and Dr. Claudette Chase is on call 24/7 in case we need her expertise. We use the clinical opiate withdrawal scale scores before and after SUBOXONE administration to assess severity of withdrawal symptoms. We provide ancillary medications for withdrawal support throughout the treatment, but mostly in the first 4 days. We use a higher dose of ibuprofen at 600 milligrams every 6 hours. We use Gravol 50 milligrams, that's also known as Dramamine, and clonidine is a higher dose again at 0.2 milligram, and it addresses the restlessness, the sweating, and the anxiety. For sleeplessness, we use the trazodone 50 milligram, 1 to 2 tablets at bedtime. This program has a number of innovations. We have a treatment team that has diverse expertise and skills. We also work very closely with a cultural and spiritual psychoeducational program and group sessions that's delivered by our elders, social worker, addiction counselor, and recreation therapist. We focus on coping techniques, avoiding addiction triggers, stress management, motivation enhancement, and healthy diversion. Grief counseling is a major component of care and assessments of concurrent disorders. The most common concurrent disorder that we see is post-traumatic stress disorder. Many of that is from the hard lives that these students face in their community. When we do see depression, we try to address it without medication or SSRIs. We use video conferencing during summer months for aftercare. We focus on relapse prevention, as many of the home communities have high use of drug addiction. Our treatment team monitors the progress and deals with any relapses. We have access to the physician for dosage adjustments. In a case management process, we assess each client, we monitor them, and make recommendations to the physician for any dosage changes. We do have a holistic student services program in our high school that consists of social counselors and a number of elders who are on site. These elders are responsible for teaching cultural programs and for addressing spirituality issues that the clients face. Our principal, teachers, administrators, and boarding homes are highly involved and supportive of the students who are in treatment. We do have access to psychological counseling. Our addiction counselor is on site daily, and we have a social worker and psychologist who we can refer the clients to. Our chiefs in the area have provided political and policy advocacy for funding and access to the critical program elements, such as coverage for the SUBOXONE. Foundations for Success. The program recognizes experiences of students. We recognize the loss and the grief from suicides, the family disruptions, and the relationship issues because of the drug addiction in their communities and in their families, as well as their homesickness when they leave their home community. The students have been exposed to opiate drugs early as family members and friends are opiate addicted. The students arrive in the city already addicted to opiates, which is a big change from 5 years ago when they came to the city and got into drugs in the city. Their exposure to opiates range from 5 years to 8 months. They use low milligrams of drugs that are very expensive in their home communities. One 80 milligram OxyContin tablet was costing $1,000. We encourage peer support and positive influences and have many group sessions with the clients who are in our program. We have a structured environment at school. There's lots of acceptance of the students and their goals to go into treatment. Our staff are flexible to the treatment program, and we have lots of cultural supports. Our drug therapy is accompanied by a psychosocial counseling, spiritual and cultural program. We have a wraparound support system with access to external resources if required. We're trying to teach healthy diversion to the young people, so sports and recreation activities have been planned in our schools, after school, and on weekends. The pilot design gave us lots of flexibility so that we could be creative in how we approach this program. It allowed the program to evolve in response to each cycle's outcomes. We made adjustments to the length of the titration period. We shifted from an off-site pharmacy clinic-based setting to all services now school-based, using direct observed therapy and caregivers on weekends to provide the SUBOXONE medication. We have implemented mandatory counseling and group participation for the students for their aftercare program. We had some barriers to success. One of the initial ones was the students' attitudes towards their own addiction, that they were either just partying, minimizing their addiction severity, and the shame about their addiction. Our clients had difficulty coping with the withdrawal symptoms during the early induction, as we had to slowly titrate the dose, and it was not controlling the pain, the vomiting, so clients turned to opiate use to control the symptoms. This was usually better by day 3 when we reached the 16 milligram dose. Continued association with family and friends who are still using. These are people they care about and people who are in their social circle, but it also triggers relapse for them. One of the barriers was the emotional burden of the unresolved trauma in their lives and the complex grief. These young people are suicide survivors. Regaining physical health, pursuing sports and other interests, being hopeful, and having personal insight were some of the successes that each of the students experienced. They started attending classes, completing their assignments, and getting higher grades. We've had 9 graduates of the 50 students treated and are now in college studies. The peer support from others currently or formerly in the community in the program have been very helpful for those who are still in the program. We have a very skilled and competent staff who are very compassionate and non-judgmental. Our success indicators are complete abstinence may not occur the first time in treatment. So we've had some students repeat treatment, especially those in the early intakes where we did not offer a maintenance program. Our students are becoming more communicative, emotionally engaged, and seek help dealing with their challenges. We see risk reduction as a result of education. While some are still using drugs, they've made the shift from injection needle use to less risky behavior like snorting. We did an evaluation. An external evaluation was conducted on the first 30 client files by the Center of Rural and Northern Health Research. A total of 50 students were treated. Therefore, we reached our goal of the pilot project. 9 students have graduated from high school, and we have 5 who are currently in treatment. 1 student remains drug-free after completing only the 30-day program. If you have any questions, I can answer any questions. You can email me as well at maycat@shaw.ca, or our case manager, who is our on-site school nurse. We do have 1 publication on short-term low-dose therapy that was published with our partners from the Center for Mental Health and Addictions, Dr. Andrei Somokolov, Dr. Benedict Fisher, and Dr. Rhyme, and that's available online. I do have a short presentation on a case study, and just to give you an idea of the complexities of the clients that we're dealing with at the high school and the need to set up a program, a school-based opiate treatment program at an urban-based high school. We had 1 young lady who came into the program she was 20 years old. She came into the 22-day intake in March 2011. We did not offer a maintenance program. When she went home for the summer, she relapsed, and so we took her into another intake, which was a 30-day program in February of 2012. We continued her treatment on a low-dose maintenance program, and she completed treatment in March of 2013. She has been 13 months drug-free. She went to the college after high school graduation and did very well in the program. She went home for the summer and became the caretaker for her nieces and nephews in her home community, as her parents and her siblings are all injection drug users. She has goals to complete her education, but has the strong commitment to keep her families, to care for her siblings' children. She struggles daily with abstinence, and she is tempted to use drugs because a number of people in her home use drugs. Her community has one of the highest rates of opiate addiction in our area and does not have a community-based SUBOXONE treatment program. She receives counseling support through our program, even though she's an alumni. She gets connected when she comes to the city. She meets with our addictions counselor, and they have telecommunications support. This client would like to come back to school, and she's hopeful that the community will be providing a community-based treatment program so her parents and siblings can get treatment in their home community. This is the end of my presentation. Thank you very much.
May, thank you so much for an excellent and informative presentation. We have some questions that have come in, and we do have time for questions. So just a reminder to participants that you can submit your questions by typing them into the webinar's control panel. I'd like to ask you, May, if you would go back to the third slide of your presentation, to the map, and ask a question in terms of, could you show us on the map where you refer to the city and where the urban area is with respect to the geography of this territory?
Okay, so if you look at the map, there's a little green dot in the yellow part that says Flying Post. Flying Post is a reserve that's about 60 miles from Thunder Bay. So the little point that you see just to the lower part of the Flying Post green dot is the inlet for Thunder Bay. So our high school is located in that city, and our population is about 110,000.
So great, thanks. Then and then just a follow-up question there is, you talked about these students coming in, flying into the to Flying Post to come to school, and do they reside there during the week? Do they go home at the weekends? Can you kind of talk a little bit about what their school schedule might look like?
Okay, so they come in for 2 school semesters. They come in September. They're all flown from their home communities. Bearskin Lake, right at the top, Sagicole Lake, Sandy Lake are some of the communities where they're the furthest north. And they fly into Thunder Bay, and they live in boarding homes. The boarding homes provide housing accommodation. And at the high school, we do provide a meal program where they get breakfast and lunch at our high school. The classes are held. We offer grades 9 to 12 courses, and they attend all classes on site. They take the city buses to our school and participate in the classes that we offer. We offer 4 classes per day. And they do that until December, go home for Christmas break, 3 weeks back to their home community, and then they come out for their second semester. They just came back last week, and they are now in their second semester classes. Our school closes on May the 15th to provide them with longer periods to be at home for the summer. So they all return home in May. We have a graduation ceremony in May as well. This year we're looking at 3 of our SUBOXONE clients graduating. And over the summer they work in their home communities, but they're also exposed to the drug use that's in their communities.
Great, thank you. One of the participants sent this question in. During the induction phase, what's the role of the addiction counselors in terms of how do they support around that induction phase? And when people are experiencing acute withdrawal symptoms, can they be in tune with counseling? I'm presuming that means connected with counseling.
Okay, so our team approach during induction is the nurse practitioners are responsible for doing all the clinical opioid withdrawal scales. If you get over 13, and that's the indicator that they're in moderate withdrawal, and we can provide the first dose of SUBOXONE. So we give a 4 milligram and then wait an hour and give another 4 milligram. The addiction counselor does an 8-page history on every one of the clients before they receive the SUBOXONE. This history goes back to some of their childhood issues, so lots of times it's triggering some painful experiences for them, and we provide supportive counseling through the addictions counselor either during or after we start the treatment. Unfortunately, the first 3 days, we always say the first 2 days of the program is the most difficult, and that's where we see most of the achy joints, the bone pain, the GI upset, and the restlessness. So we use most of our ancillary meds during that. Our addiction counselor works with the clients to help them manage their symptoms. And it's mostly through education. So when to take the ibuprofen, when to take their clonidine, making sure they're eating and sleeping, and that's the role that the addiction counselor has.
Great. There's when you were talking about the treatment or when students present with symptoms of depression, there was a question that came in about the reason for avoiding SSRIs for depression, and I think the way I heard it was that your first line approach is not to use medications, but can you just clarify that for us?
Yeah, I think, you know, we've been challenged by the clients and their presentation of their issues. They come with more anxiety that we've linked to post-traumatic stress disorder. So our grief counseling seems to address better than adding another medication on board. So we try to avoid, I mean, if people were suicidal and they were, we couldn't stabilize them and we felt they were a self-harm risk, we would use an SSRI. But we haven't had this age group present as significantly depressed and scoring positive on depression scales, whereas it seemed to be situational and not clinical depression.
Great, thank you. I have a personal shout out from a classmate of yours from the Northern Nursing Program at Lackhead U, and she's currently at the Brantford Aboriginal Health Center, and she just wanted to give you feedback on a great presentation, and kudos to you for all the work you've done, that it's truly inspiring, and congratulations on a job well done. And now the question, where do you see this program going forward in the future? Will there be other sites available to offer this type of treatment?
I guess at our high school, we feel that we still have an obligation to provide on-site treatment. So we've had approval to continue the program. Through non-insured health benefits, we'll continue to cover the SUBOXONE while the students are at our high school because they're deemed to be temporary residents in a city. The exclusion for receiving SUBOXONE through non-insured is if you don't have access to methadone, you can receive SUBOXONE. SUBOXONE's a little bit more expensive. I think it's like, I don't know, $5 a pill for an 8 milligram tablet, whereas methadone is 35 cents a day. So the cost is a factor. What we hope to do is we've just been funded for provincial funding for our aftercare program. And what we are doing with our aftercare is the strong emphasis on the culture and the use of our elders, and then building more coping skills with the client through education. So we're hoping as long as there's a need and as long as there's no programs in the northern remote communities, we will continue to provide treatment in our high school. Now, in those northern remote communities that you see the cluster of dots up in the top left-hand side, there are about 16 community-based programs now, SUBOXONE treatment programs. And non-insured health benefit, who's the third-party medication funder for Status Indians, has approved SUBOXONE for community members who live in remote and isolated First Nations. So if you don't have road access, your clients have access to SUBOXONE treatment.
Great, and that really leads into the next question. Is there support or treatment offered to the students and family members that remain addicted?
You know, I've worked in one community. I said I did 50 trips to the north. I have 3 communities that I'm providing treatment in right now. Our high school program has been invited on site to some of these communities to help them with the opiate addiction because it's just so prevalent. So we've gone up there and we have about 400 clients that we've treated in the last couple of years. And the doctors who are, so there's a mobile team approach for SUBOXONE treatment, and then there's a physician-led program in some of these other communities. It's not meeting the needs right now because there's an estimated 33% of the population has an opiate addiction. So if you put that in perspective, there's a population in Sioux Lookout Zone that's 25,000 First Nation residents in 28 First Nations, and there's an estimated 9,000 of them who have an opiate addiction.
Wow, that's really stunning. And clearly that points to the need for increased access to treatment. Another question that came in, has there been a use of any internet-based tools to support this program? So is access an issue? And so I think looking at the map, are there students that just aren't able to access to come into school and to access the school-based treatment?
Because our work is all on site in the high school, our team only works with students who offer treatment to students who are only in the school studies, the academic courses that we offer. But once they complete and are alumni of our program, we will provide continued aftercare through technology. We have one of the best broadband systems in all of Ontario in those northern remote communities. One of the things that we provided to our clients is iPads so that they could participate in FaceTime with our counselor, or they could come online and deal with our video conferencing. So these kids are so good with technology, they make high use of the links that we put up to get ongoing drug education as well. So they will go in and they will link into some of the sites that we post so that they can get some ongoing support.
Great. A question about access to the journal publication and wondering if people aren't able to access that, is there a way for them to obtain that?
They can email me, and I know I have a copy of it that I could send them.
Okay. All right. So your email address is on that last slide for people to access.
Yes, they can call. If they have other questions, they can email me as well.
Great.
And I could send them the, I could just email them the article.
Great, thank you. Have you had any problems using so many of the sedating medications that you mentioned, the clonidine, the trazodone, the Gravol?
You know, if you look at some of the young girls, because they're smaller in stature, we've had to cut back our clonidine and use a 0.1 milligram instead of the 0.2, so we just break the tablet in half. They tend to, you know, the first 3 days are kind of where we use the highest amount of the clonidine and the Gravol and the trazodone. When we start weaning them down again, they tend to use more of the ancillary medications. So when we're down to 2 milligrams, 1 milligram, every time we do a transition, they start to get achy joints and bones again. So the ibuprofen, the 600 milligram, We're kind of careful with it again because it can cause some GI upset. But if it's used according to the way it's prescribed every 6 hours, it does take care of some of those achiness. The transition from dose where they will feel a little bit of SUBOXONE withdrawal it usually lasts about 3 days, and the students describe feeling like they have a mild flu.
Another question, are there any centers that are providing traditional medicines to support methadone and the SUBOXONE programs?
I know that we have community-based programs that have implemented what we would describe as some land-based healing and some culture-based programming. Now, the land-based healing is using land medicines, herbal medicines that they get, and also to go out onto the land, to be able to go out and do camping trips. We did that over the summer with one of our communities. So the land-based healing programs are not funded, so the bands have to pay for those themselves, but they actually can build stronger coping skills with these individuals if they're using that. Our culture-based programs are mostly the ceremonies. So they actually use the sweat lodges. We have sweat lodges, moon lodges, and night lodges.
Great. The question about how to go about getting the SUBOXONE education certificate. So you mentioned that was something that was obtained, and could you talk a little bit about what's involved with that and how to access that program? Okay, so it's free. There's 6 modules, and you go online and you do www.suboxonecme.ca. And you can go in and out of these modules. So you would do one module, you can quit that. They ask you a little test at the end of the module. Once you've successfully completed each of the modules, it'll give you a link where you print your certificate, and you can email yourself or your own certificate that you can use for your, store it in your computer. It's all about the pharmacodynamics of the medication and the safety features that we have to consider. For nurses, if we're working with a new drug, we have to have the theoretical component of the education on that drug. So the SUBOXONE CME will give you that education. And then when I work with the nurses that I take to the north or have at the high school, I will do the on-site education on how to administer the medication. It goes under the tongue, and how to document, because it is a narcotic. Great. Can you just say that website once more to make sure that people have got that?
It's www.suboxone, SUBOXONE, and it's all lowercase.
Okay, great. We had a couple of questions come in that I'm going to field, May. One of them is about, first of all, lots of congratulations on your exemplar programmer coming in. So it's clearly the presentation has impressed people in terms of this exemplar program. So congratulations again. There was a question about whether this can be applied to veterans, And another question about primary health concerns for fetus that are exposed to methadone and SUBOXONE. And I just want to take this opportunity to let people know that the webinar series has been going on for about 2.5 years now, and all of the webinars are archived. I'll mention the website again at the end of the conclusion of the program, but those webinars are archived, and there have been webinars associated with specific to veterans and specific to women who are pregnant and opioid dependent and on methadone and SUBOXONE. So I would refer you to those resources. Thanks for those questions. And so May, back to you. As a program that specializes in engaging youth and to co-develop tech tools, I'm glad to hear that you use tech tools for support. And there's a shout out for mindyourmind.ca, where there's other tech tools that are available. So that's Mind, M-I-N-D, YOURMIND, one word.ca. And another question, are there opportunities for training about prescription drug abuse or opiate misuse for First Nations?
It's hard to find one source of education. I certainly went to lots of literature. You can do a literature review. I've read clinical trials from the U.S. and Australia that were really well done. I don't have all the links to those articles. I don't have a reference list. Would be nice if I could find one. But if you just Google SUBOXONE treatment, you will find a number of articles in the U.S. that you can start reading. Experience, again, the more contact you have with clients, the better. You know, we talk about knowledge, skills, and attitudes that nurses should have. We upgrade our skills through the knowledge and our own pursuits of information. On-site, working with clients is how you get your skill development. Again, having that non-judgmental compassion for the people that you work with is probably your best skill set. We've had high participation in our program. We've had no dropouts of all the students that we've taken in, and we have very low relapse. And we're not sure what the variables are for that success, other than we do individualized care for each one of these clients. Although it's a set protocol, our aftercare seems to be tailored to each and every one individually.
So I think what you're really emphasizing is the critical importance for culturally sensitive treatment, but importantly person-centered treatment and care.
Yes, and you know, even if you're not Aboriginal, you can still adopt the acceptance of the client and how they ended up where they are, but more importantly, how to support recovery. And you know, we tend to focus more on a strengths-based approach instead of always looking at poor decision making. We're dealing with adolescents. We know they're going to make poor decisions, and we just help them make better decisions.
Great point. Great point. Are you familiar with any other studies going on in First Nations that are similar to the programs for youth, and particularly this comes from British Columbia, specific to anything related to British Columbia?
You know, it's interesting. SUBOXONE, 75% of SUBOXONE is used in Ontario, but the second province that uses SUBOXONE is BC. And that just tells you that that's where the opiate addiction is hit hardest in our communities. But in terms of research. The only research that's ongoing now is on SUBOXONE. According to Dr. Benedict Fisher, is the research that we're doing. We have 200 client files that we're putting into a database to be analyzed, and we're going to be publishing another article on opiate treatment in these northern communities, because they're using such low dose opiates, but so SUBOXONE can be used for a shorter period of time.
Great. And we're coming to the last couple of questions, so if you could just a quick response to this one. Who does law enforcement in the territory? Is it RCMP or another agency?
We have our own police force. It's called the Anishinaabe-Aski Police Services, and they're an Aboriginal police force that provides policing in each one of these remote communities.
Great, great.
So they're called NAPS.
And then just one final question is, are you utilizing opiate overdose protection, like prevention training? And this comes from the states, in particular New York State has had a lot of success with this. The state-operated inpatient addiction treatment centers are training interested clients, allowing them to have a kit including 2 syringes or vials of Narcan, and the asker says that this is really saving lives.
We have not done that in our communities. I think it's being considered. We haven't had any overdoses other than from methadone, when people are using diverted methadone. City of Toronto was the first one in Ontario, I think, to implement the Narcan kits, but we haven't done that, and it's certainly something that if we saw a need to, it would be a good tool to use.
Great. Well, May, I want to thank you for your generous time and your fabulous presentation. Our time is now up, and I want to thank everyone for participating in this webinar. Shortly you will receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey. We would ask you to take a few minutes to access it and provide your feedback on today's sessions. In the next day or so, you'll also receive an email from the Registered Nurses Association of Ontario that includes a link for a short evaluation survey. Once the survey is completed, you will be able to print a certificate of completion. This survey will greatly assist the Registered Nurses Association of Ontario in evaluating this webinar and for planning for future webinars. The webinar today was recorded and will be posted on the website of the Physicians Clinical Support System Opioid Therapies in the near future. That site is www.pcss-o.org. And that's also where the webinars are archived. And a calendar of upcoming events and helpful clinical resources are available there as well. All of this information can also be found on the website of the International Nurses Society on Addictions at www.intnsa.org. We hope you will join us for upcoming PCSSO sessions, and we look forward to continuing to collaborate with our Canadian nurse colleagues in the remainder of this series. And that ends our webinar for today.